a new role between hospice and the Children's Community Nursing team as a palliative care children's community nurse, really, bridging the gap between hospital, community and the hospice. This was a neonate from the local area who had a genetic mutation, and this caused him, amongst other things, to have empty bone marrow, so he wasn't able to regenerate that. So in his time on the neonatal unit, he received blood transfusions and platelet transfusions every couple of days to kind of keep him, topped up as such. In that time, he had some significant periods of sepsis requiring IV antibiotics. They went out to second opinion to see if he would be a candidate for bone marrow transplant, and sadly they decided he wasn't able to. So that was when they kind of started to involve the palliative team. Originally, parents thought they were going to be able to go home for a period of time and continue to receive blood and platelet transfusions. This caused some discussion around whether that would be in his best interest, and it was decided actually it wouldn't. Parents had never been able to take him home, so one of their main wishes was to take him home. They wanted to go to the farm, they wanted to go to the beach where they lived, and they just wanted to have a bit of that newborn time at home with him. Initially, we thought we were only going to be able to provide a couple of hours at home until we started to kind of unpick what we could do. So myself, the hospice and our consultancy team worked to see what we could provide. We worked with another local children's hospice to provide a 24-hour on-call across 4 days and five nights. This just allowed them to go home, and the parents were so grateful. And the timeline for this family worked really well, because at the point that we went to the hospice, the family felt they were ready and they needed that little bit more wraparound support. So that worked really well for them. They got to have a takeaway on the sofa. Dad got to go for some beers with his friends. They went to the aquarium, the farm. They went for walks along the beach. They had family visit. They had, the right amount of time at home for them. They then had a spectacular time at the hospice as well, where they went to the zoo and for meals and, out to the local area. So they really did, it really captured what they wanted for him, as much as it could. I think they just got to take their baby home without knowing any of the cogs that were going on behind the scene. And I think that's the most important thing. They got their choice and they didn't need to know about the work going on behind. I think the family were very in tune with healthcare and social care services, and were just so grateful to have that opportunity, and were really happy that they could maybe pave the way for this to happen more often when the statutory services couldn't provide it, that hopefully hospices can work together to provide that for them. So their wishes were to kind of share it and try and make sure that other families got the opportunity that they had. When he transferred home, I met them at the home, settled him in, did that initial kind of contact. We had contact agreement each day of a telephone call, and that led to a visit on most of the days. And then on the Monday, I did a joint visit with one of our doctors to review how that had been over the weekend. And before they took him in the car to the hospice, I went out to check he was okay and that we didn't need, obviously, the end of life transfer. So once I then went and met them at the hospice, introduced them to the hospice staff and settled them in. Again, I think it worked in a really lovely way. I think we did some really nice partnership working. It was quite integrated. I think when you are in a hospice, you have a lot of different staff coming and going. When you're giving end-of-life care in the community, it's quite one-to-one. There's not many of you. You get to know a family well, and I think it's really important that when they go to the hospice, if we've given community care as well, that we're working with the in-house team. So when I was in the hospice, I would go down and see them with one of the in-house nurses, supported with symptom management with the consultants, and yeah, just worked alongside the in-house team really. Since then I've worked alongside family support, and it's something that we've said that's quite different to the hospice, because in-house patients, family support would just pick up the bereavement part, but in the community, again, it's sometimes a different working relationship, so that contact does continue a little bit. I went out to collect equipment, we ended up having a 2-hour visit, so I'm working with family support on that, on who contacts them when, and then I will step out and they will obviously continue it through the pathway. So I think again it was a really nice example of it working and how we would want it to work in the future. They have been on neonates for about 4.5 months. I know when he was initially born he was really very, very unwell and had a lot of interventions. And then they had this period of time where he was comfortable and he was receiving his blood and platelet transfusions, and all they'd ever known was neonates really. But they really did want that part to be home. I think for mum, when she looks now, she really enjoys those memories at home, but she still associates him with the hospital because he was there for so long. So but they got to do the things that they wanted to do and just be a family in their own environment. They very much loved the neonatal unit, but they said they did feel like they were in a goldfish bowl a lot of the time, and they just wanted that time to be at home and sit on the sofa more than any of the trips out or anything. They wanted to sit on the sofa with their newborn, and use all the things they'd bought for him. They got to build his pram and use his pram, and they were really excited about that. When we are on call as a children's community nursing team, we need medical support to enable us to give that symptom management at home in a safe way. This is one of the challenges that is happening across the network at the moment, because we don't have enough doctors who are able to support a 24-hour on call along with the other posts they do. And obviously our palliative consultants can't provide that across the whole Wessex network. So we looked at it proactively and in a new way, and we used a virtual bed at the hospice. In this instance, that meant that we were able to use the hospice doctor for our medical cover. So our hospice and the other local hospice were able to contact the hospice if we needed support with symptom management, and they would get the doctor to call us to provide us support. It obviously also meant he could come in to the hospice at any point, which they can when they're end of life anyway, but it just kind of closed that circle. So it allowed us the opportunity to take him home without having to find a consultant to provide that, at last minute on a Friday, as it was a Friday, as usual. And it worked, it worked beautifully in this case. The nurses who were on call at the time were all very experienced nurses who have worked in palliative care. So we would be absolutely fine with telephone support. Across the network in the different areas, it's often done in different ways. So some of the local doctors still come out and visit the home. And I think it's something that we need to move away from, and trust that and that our nurses are skilled enough to provide that assessment and that symptom management in the home to be able to do it via a virtual bed and a telephone call, or virtual review. So for me, it's having that doctor at the end of the phone that we can give our symptom management questions to, and often it's we're relaying what we see and what we think is needed, and they just support in that. So it worked really well in that case. I think I have discussed that maybe if we have more junior nurses, they would maybe struggle with it more if they've come from an area where they're used to doctors coming out. So it's just changing that way we're approaching it and making sure that we've got that kind of skill and confidence in our nurses, and that moving forward this is the way that we would do it. I think the most celebrated thing is getting him home and meeting the parents' wishes. I think straight off that's the most thing that we should celebrate, because it just met what they needed and it met their wishes. I think another thing to celebrate is that it did, in this case, seamlessly come together. There was some excellent multi-professional working, all teams pulled together to, you know, to meet the wishes of those parents. And I think that should be really celebrated as well, because, you know, I think it's probably the first time 2 hospices have done an on-call together. It's the first time our hospice has done an on-call. The Integrated Care Board were on board with anything that we wanted to do. So it was just so nice to see all professions coming together in the best interests of the family.